Hello, everyone. We're going to cover some trauma. We're going to cover some basic trauma management, and for many of you, this will be a review. I hope to insert some new concepts and considerations for managing, simple and complex trauma patients. First of all, let's talk about the golden hour. A lot of people talk about the golden hour. It comes up frequently when we talk about trauma, logistical considerations for, how we get the patient to the hospital. And it kind of helps determine our mode or method of transportation. Are we going to transport a patient by ground? Are we going to transport by ambulance? And stay and play is a popular concept or construct for us. We talk about stay and play versus load and go frequently, and a good clinician knows when it is appropriate to stay and play or stabilize on scene versus realizing that the interventions that the patient really needs is beyond our capabilities, and we need to load the patient as quickly as possible and get them to the hospital and perform meaningful interventions en route. But for the golden hour, it's kind of arbitrary. So when we talk about the golden hour, it's really kind of a myth in many ways. And in this article that I'm referencing here, it says this article discusses a detailed literature and historical record search for support of the golden hour concept, and none is identified. So there is actually no literature that supports the concept of the golden hour. So what we've been saying all along is a urban legend, the golden hour. And I think that a lot of this comes from helicopter EMS services. And of course, there is something to be said, depending on your geographical location, about utilizing a helicopter for certain populations. But there just is not much literature out there that really supports this. And, a lot of places put their hand on the Bible and say, you call us, we're going to save lives, and it's just not borne out in the literature. Now, that doesn't mean that there isn't a period of time in which, it doesn't mean that there is not a golden period, okay? There is a golden period. We don't know if that's a golden hour or not. It might be a golden 15 minutes, but it's going to vary from patient to patient. And there's a lot of literature looking at EMS scene times or transport times as it relates to outcomes. This was a very recent article, hot off the press, from EAST, which is the Eastern Association for the Surgery of Trauma, and Dr. Bernard at UK, one of the trauma surgeons. He is part of this organization. And their conclusion, what they came up with, was that pre-hospital procedures in penetrating trauma patients impart no survival advantage. No survival advantage, and may be harmful in urban settings. Even when performed during transport. So how does this make any sense? Even if you're loading and going and performing these procedures during transport, how is it possible that interventions that we've been taught for decades that are supposed to be beneficial for the patient are not? And if you look into this article, they're talking about everything from starting an IV to needle decompressions to managing the airway. And the conclusion was that we should forego all pre-hospital procedures in lieu of immediate transport to improve patient outcomes. Now, I sent this article to Dr. Bernard and to Dr. Hilty, and they were a little disappointed in the conclusion, because a lot of people look at these articles and they just simply look at the conclusion and then some people may automatically infer that that means that we should literally not do anything. No, that's not the case. What it means is that specifically in penetrating trauma patients, the most meaningful intervention that we can perform is immediate transport, load and go, keep scene time short, and do everything that you need to do on the way to the hospital. And that's what I think that you need to conclude from this paper. And both Dr. Hilty and Dr. Bernard both said, yeah, it's a silly conclusion. And of course, we're going to still provide the interventions that the patients need. But it does bring up some important considerations for penetrating trauma patients. And why is it specifically penetrating trauma patients? Well, penetrating trauma patients are those that if any trauma patient's going to survive, it's penetrating trauma patients. So we typically separate penetrating trauma and blunt trauma for good reason, because blunt trauma patients specifically, if they don't have a pulse, when we get there, their survival rates or chances of surviving is virtually zero. There's some very limited conflicting data of blunt trauma patients in very specific settings, such as settings where there are high risk. There are athletes participating in high risk motorsports, where if you can have a highly functioning team be on top of them within minutes or seconds of them going into cardiac arrest, they then can have a high survival rate. But that is infrequently the patients that we are treating. It may be that we get there seconds after they arrest, and law enforcement or other bystanders say, hey, we saw them breathe right before you got here. Then we may approach that patient a little differently. But generally for penetrating trauma patients, they can and will survive if we provide the most important intervention for them, which is immediate transport to a trauma center. And this is not the only article that has looked at this. There's been a number of them specifically looking at patient survival rates when you compare police transport to EMS transport. And this is a very sobering study, and there are multiple like it. And you can easily look that up, where it compares, did the patient survive, or what was the survival rates of patients with penetrating trauma when you compare police transport to EMS transport. And it could be that as EMS providers, we feel like we have to do certain things, that particular interventions have to unequivocally be performed before we get to the hospital. Take starting an IV, for example. When we looked at our scene times for STEMI patients, patients that met STEMI criteria, of the ones that the scene times were longer, and when I have interviewed the EMTs and paramedics that were on the longer scene times, frequently what I've found is that they start an IV before they leave the scene. And this is possibly true for trauma patients. And we feel like there's a stigma attached to being in EMS and getting IV access. But it's not, honestly, all that of an important intervention. And we put a lot of emphasis on it. And my take on it is that if I can't get an IV in the back of a moving ambulance, and the patient starts to crash, then I can always start an IO. And if I don't need an IV to perform an intervention, and the patient arrives at the hospital without an IV, and the receiving facility gets mad because they don't have access, well, it is entirely within their scope to start an IV as well. So do not delay transport to perform non-meaningful interventions. And it is as simple as that. So in no way should a patient being transported by police be associated with higher survival rates than if they went by EMS. That just does not make sense. And the only rational explanation that I can think of is it's because EMS feels like they have to do certain things. So as a competent EMS provider, you have to decide, does the patient need emergent transport because they have something, the hospital has something that will help them that I don't have, or do they need emergent treatment? If I don't treat them right now, then they are definitely not going to survive. And you have to be able to decide that. And you have to be able to make that decision when you have the patient in front of you. But in almost every circumstance, when it comes to penetrating trauma, the answer is almost always going to be they need emergent transport. So what do we need to take from this? Limit scene time for only the most critical procedures. Transport immediately to the nearest trauma center and perform procedures en route. So let's talk briefly about your scene management and primary survey. This is... All right, so let's talk briefly about scene management and primary survey. And I think when we're talking about scene management, we can't effectively manage a scene without good communication. And there are a few different communication concepts or constructs that we're going to cover that I think will be beneficial for everyone. One is the 0-point survey. It's a new concept, and these kind of pop up, every few years, different ways, different checklists to prepare yourself and prepare your team and make resuscitation more fluid and make everyone work together more effectively, if you will. And the 0-point survey, there's actually a video that I'm going to play from Cliff Reed, who is a flight physician, a very excellent speaker, and I just love listening to his talk. So I won't go into too much detail about this, but there's a pre-resuscitation phase and a resuscitation phase. And the pre-resuscitation deals with making sure that you are physically ready for the resuscitation. It talks about physical, not only just physical readiness, but also cognitive readiness. Am I in a place where I can effectively resuscitate this patient? And then it talks about your team, identifying a leader, allocating roles, and briefing them. And I think that this is not something that we do frequently enough. Okay, and in many situations we have complicated resuscitations where there is no clear leader that is identified, and resuscitations can quickly go from chaos to even more chaos. They have a tendency to devolve instead of evolving the way that we want them to. So if we don't maintain control of the situation, then they are going to evolve into chaos, and that is definitely not what we want. We also have to prepare our environment. This might mean securing the scene with law enforcement. It might mean creating the space that you need to effectively treat the patient. And we talk about this a lot. If you don't have 360-degree access to the patient, and you're in a situation in which you can, if you just either move the patient or move objects around the scene, then do so. And lighting is important. If you don't have the proper lighting, it can definitely make the scene more chaotic. And of course, noise and crowd control. Now, of course, we operate in an environment where not all of this is possible, but there are many times, many situations where it is possible. We just have to make it so. All right, and then of course there's the resuscitation commenced. The P is for patient. You conduct a primary survey. And then the U is update. You share a mental model of the patient status. Now, we need to be communicating a lot on complicated scenes and complicated resuscitations. Unfortunately, we don't do this, and I've heard from other people that, well, I work so well with this person that we don't have to communicate. And I think that's okay, but I think that's also how mistakes can happen if we do not communicate exactly what we're thinking. And a mental model of the patient status simply is, here's what's going on with the patient, here's what I think is going on, here's what could be causing it, and here is what I want to do. And what I want to do would be covered in the P for priorities, which is identify team goals and set mission trajectory. So the 0-point survey, just think step up, STEPUP, step up. Relational coordination is another construct for communication for high-performing teams in difficult environments, so healthcare providers. And I highlighted a section here that says these relational attributes are reinforced by communication that is timely, frequent, accurate, and problem-solving based. So here are the different phases and the targets of relational coordination. All right, so there are 6 different briefing phases, and throughout each of these phases, it is specifically knowledge sharing and maintaining mutual respect. All right, so the focuses and the emphasis of relational coordination are knowledge sharing and mutual respect. And mutual respect starts the minute that you get on scene. It is thanking everyone for coming and using first names. Now, if you're on a call and you request assistance, yeah, of course people have to come, but you should still thank them for coming regardless. And here's the problem with not setting the tone of mutual respect early on. If you offend somebody, all right, it's going to make your life more difficult, because if someone feels like you have made them look bad in front of everyone else, then the rest of their call, they're going to want to redeem themselves. Someone who feels respected, who feels like you are grateful, like they are included, is someone who wants to do things that you ask them to do. And of course, everyone is different. Everyone responds to different. Everyone is different. Everyone responds to feedback differently. So you need to know your team and how they best respond to feedback. Someone may respond better to more direct, in-your-face feedback. Here's what I need you to do, and I need you to do it now. While some may respond better to not so, or to more. While some may respond better to less direct or indirect feedback. And so you start with introductions, and following that, you explain what you know, right? So if you're on a call with you and your partner, and then the rest of the team shows up, then you provide more elaborate details, such as the age, the vitals, and what this means for the team. This is especially important, and I think that this lays a good foundation so that everyone on the team has the same knowledge, so that we're working with the same foundation. All right, and then you provide what you expect based on what you know, or given the details of what you know. Here's what you expect to happen within the next 10 or so minutes, and here are my priorities. So let's imagine you have a complicated trauma patient. the team shows up, they're bleeding out, the airway's not patent. Here's what we have. I have a 40-year-old female patient, weak radial pulse. I've identified multiple fractures, possibly decreased breath sounds. And here are the priorities. Going with our March algorithm, we have to manage massive hemorrhage first. You're going to set that as a priority. Maybe obtaining access would be a priority. And we expect the patient to decompensate if we don't get X, Y, or Z completed. So you provide a big picture. Here's what we need to do to properly care for this patient. This could change, all right? Given what we know, this could change with these potential complications. So you might need to change directions. You set a trajectory, all right, of care. But the team needs to know that if something happens, right, if you have different information, that trajectory could change. All right, and then after that, then you start assigning roles, and we infrequently do this. And I have seen, based on my discussions with people, with providers at this agency, that many issues have came about from not properly assigning roles, or from people wanting to do things, all right, without letting the team leader know that they're going to do them, all right? These calls are very complicated. You have to assign roles early on, and you need those members that you assign the role to run through their role, right, so that they clearly understand them. And this occurred recently with a patient, with a crew member who was managing the airway, right? And we found out that the airway was, not patent, but that was not communicated to the team leader early on. So a significant period of time had lapsed with this patient not having a confirmed patent airway, confirmed with waveform capnography, and the rest of the team did not know this. So, if you're intubating a patient or placing an advanced airway, as soon as you place that, you should have end-tidal on, right? End-tidal CO2 with the first breath, and if you don't have it, you need to speak loudly and clearly so that the rest of your team knows that you don't have waveform capnography. And of course, if you're managing the airway, you will likely need more than one person to manage that. So you would say, hey Floyd, you and so-and-so, you manage the airway, report back to me after the airway is secured. And then lastly, suggestions and concerns. You don't want to, if you've got a complicated patient and you're openly sharing your thought process and what you're thinking, you kind of want the input of other people. So recently we had a cardiac arrest and we had a patient with a wide complex PEA. I confirmed with the other providers on the scene to make sure that they also thought it was a wide complex, and I said, okay, so I suspect either a tox or metabolic cause. I think we should administer sodium bicarb and calcium chloride. Do you all agree? And then everybody, of course, agreed. So I wanted other people's input because I needed that affirmation, or I needed that confirmation from them, all right? And if I miss something, I want to know. And we do this when we're terminating resuscitation. When we have a patient that we've met the protocol requirements, we say, okay, we have resuscitated this patient for 20, 30, 40 minutes. We have provided this intervention, this intervention, this intervention. I plan on resuscitating. I plan on terminating the resuscitation, or I plan on contacting med control to terminate the resuscitation. Does everyone agree, or does anyone disagree? or does anyone think we should do something else? And recently, we were terminating a resuscitation, and someone said, well, look, can we go a few more rounds? I'm like, oh, absolutely. I would feel more comfortable myself if we went a few more rounds. That is a good suggestion. So we should definitely encourage others to speak up and say something, and the way that we encourage them to do so is by eliciting and asking for suggestions or concerns. So I really want everyone to start incorporating relational coordination into their communication on routine and day-to-day calls. We need to build this into our communication framework, and I think that patients will benefit from this, and there will be less near misses. We'll have less issues with one person trying to do everything on a cardiac arrest. We will have team leaders identified early, and you should find that complicated patients will become less complicated when we share knowledge, when we assign roles, and when everyone demonstrates mutual respect during the resuscitation.